Okay, so today in this lecture, we shall talk about the management of shock. So what is shock, definition of shock, classification of shock, pathophysiology, clinical manifestations, everything was already discussed in the last lecture. So here we shall mainly talk about the management of shock. So this shock is management of shock is mainly discussed under three headings. That is your monitoring, patient monitoring, the general measures, and the different drugs which are used, the different vasopressors and the inotropic drugs which are used. So one by one we shall discuss. First, let us talk about the patient monitoring. So what are the things which you should monitor in the patient? Last lecture, I have already told you about the cardinal features of shock. That is, patient usually comes with a fall, decreased blood pressure and tachycardia and tachypnea. So here you have to do the clinical monitoring, okay, so of the pulse, blood pressure, respiration. What else? The ECG monitoring. Okay, so do the ECG monitoring, okay, so of the cardiac rate, rhythm. Okay, so look for the arrhythmias. Okay, so these are the different things which you have to look for. Anything else? Yes, you have to also go for the ABG, arterial blood gases. Okay, so arterial blood gas analysis. Okay, so here you have to look for the pH. Okay, so whether if there is acidosis. Okay, so then you have to correct the acidosis. Look at for the pH for correction of acidosis. Look at the oxygen levels. Okay, so for the correction of hypoxia. What else you can do? We also measure the central venous pressure monitoring, CVP, central venous pressure monitoring, or the inferior vena cava diameter using an ultrasound for knowing the blood volume. Okay, so by through this, by knowing, by getting an idea of the blood volume, by knowing the blood volume, it will help us for guiding the fluid replacement. Okay, central venous pressure monitoring. What else? In the cases of cardiogenic shock, we usually do the pulmonary capillary wedge pressure monitoring. Okay, using the Swan-Ganz catheter, we monitored the pulmonary capillary wedge pressure. Okay, pulmonary capillary wedge pressure monitoring is done. And we also do the urinary catheterization. We measure the hourly urinary output. Okay, and last, optional, that is the arterial catheterization for measuring the arterial pressure. Anyhow, that's optional. So these are the main things which you have to do in the patient monitoring. As I have written down, you can see here, we have to monitor, we have to see the pulse, blood pressure, respiration, heart rate, rhythm, ABG, pH, CVP, central venous pressure, pulmonary capillary wedge pressure, urinary output. Okay, so these are this thing is seen if the patient has got a cardiogenic shock, and this is measured for, it guides us, okay, so for the fluid replacement. Okay, so this is your patient monitoring. Next, come to the general measures. What are the different general measures which you should do here? So care of the skin, airway, okay, so bowel, bladder, nutrition, the basic general measures. Then if the patient is having anxiety, pain, anxiety, that should be alleviated. Then the patient should be placed in, what is the main common thing which is done? The patient is put in a horizontal position with the legs slightly elevated. Okay, the head and sorry, the leg. Okay, so that is slightly elevated, right? So this is what it is. This is, he or she, should be allowed the most comfortable position. Then we are going to correct the hypovolemia. How are you going to correct the hypovolemia? So this correction, it is based on how much the amount and the nature of the fluid. So we have to correct the hypovolemia, because if the volume, the decrease in the volume, blood volume, so depends upon the nature and the amount and the nature of the fluid lost. Okay, so depending upon the clinical state of the patient. Okay, so depending upon the CVP, the central venous pressure, just now I told you, or depending upon this PC, this pulmonary capillary wedge pressure, pulmonary artery wedge pressure. So depending upon all these things, we take measures to correct the hypovolemia. So hypovolemia, that can be corrected by, usually we go first like this, we can correct it by using the isotonic saline solution. Okay, we can use the ringer lactate solution. Or if there is a blood loss, okay, so we can give blood. Okay, so it's corrected by blood transfusion. Okay, so or you can give dextran, albumin, plasma. Okay, so depending upon the situation, accordingly, these are the common things which is given for the volume correction. Okay, So next, after correcting the volume, next what are you going to do? You have to prevent and treat the renal complications. So this is one of the most feared complications, that is your renal complications. We have to prevent, if the renal complications have not yet set in, we have to prevent the renal complications, or we have to treat the renal complications. So in the initial stages of shock, usually there is, as I told you, there is renal vasoconstriction. Okay, so renal vasoconstriction. Last lecture I had told you there is oliguria, and there is decreased GFR. So renal vasoconstriction, the blood flow to the renal tubules, okay, that is decreased, and that can lead to ATN. What is ATN? Acute tubular necrosis and renal failure, acute renal failure, if it is not promptly corrected. So you have to protect the kidneys so that these two things don't occur. To protect the kidneys, you have to, rapidly and adequately, you have to correct the hypovolemia. And here there is no role of diuresis with furosemide or mannitol. Okay, so here mainly you have to go correct the hypovolemia. That will help in preventing this acute tubular necrosis or acute renal failure. But you might ask, what will happen if it has already set in? If by the time patient has come, you find that the patient is already in acute renal failure, then you have to treat accordingly, the treatment according to the acute renal failure. Okay, so first correct the hypovolemia, then try to prevent or treat the renal, renal complications. And then next, what we are going to do, this is number 1, this is 2, then this is 3, correction of hypoxia. Look at the blood oxygen levels. If it is less, then you use face masks. Okay, if necessary, you can intubate the patient, mechanical ventilation. Okay, so you have to correct the hypoxia. Then what else? What other complications can occur in patients of shock? There can be acidosis. So how are you going to correct acidosis? By intravenous sodium bicarbonate, only if the acidosis is severe. Okay. And if the patient has also developed cardiac arrhythmias, then what are you going to do? In this, we mainly, if the patient has developed cardiac treatment of cardiac arrhythmias, you can give drugs like I told you, amiodarone, lignocaine, or cardioversion, pacing. Okay, so cardioversion or pacing, these are the different treatments if the patient has developed cardiac arrhythmias. And what will you do if the patient has, you find that the shock is because septic shock? Septic shock, what are you going to do? Obviously, you're going to use antibiotics. Okay, so if there is any abscess, you're going to drain the abscess, or if it's a case of septic shock, you have to use intravenous antibiotics. And remember, low dose corticosteroids, they can be used only in the early stages of septic shock. So this is often asked, corticosteroids is used in which type of shock? Corticosteroids is used in the early stages of septic shock. So I'll write it down once again clearly. So what are the things I told you in the management of shock? First, come to the patient monitoring. In the patient monitoring, what are the points I told you? You have to measure for the blood pressure. Okay, so measure for the respiration, respiratory rate. Okay, so look for the pulse. Okay, so measure through the ECG, measure the cardiac rate, rhythm. Okay, arrhythmias, look for the ABG. Okay, do the ABG, atrial blood gas analysis, look for the pH, look for the correction of acidosis, look for the central venous pressure monitoring, or the inferior vena cava diameter, the pulmonary capillary wedge pressure in case of the cardiogenic shock using Swan-Ganz catheter. You monitor the urinary output. Okay, so these are the different things you are supposed to monitor. Then in the general measures, what did I tell you? Just keep on thinking what happens in the patients of shock. Accordingly, you can get the general measures one by one. So obviously, first you should take care of airway and the skin and bowel, bladder, nutrition. Place the patient in horizontal position with legs slightly elevated. And next, what is the treatment approach? First and foremost, correct if the patient what is the status? What is the clinical status of the patient? Okay, so look at the amount or the nature of the fluid lost. Accordingly, you are going to replace it using isotonic saline or ringer lactate or blood transfusion if there is loss of blood, or albumin, dextran. Okay, then what are you going to do after hypovolemia correction? You have to prevent and you have to treat the renal complications. As I told you, it's one of the most feared complications because due to renal vasoconstriction, what is going to occur? Due to renal vasoconstriction, there is going to be acute tubular necrosis and acute renal failure. So first we'll try to prevent it by correcting the hypovolemia, rapid correction of hypovolemia. And if it has set in, if already there is acute renal failure, accordingly you have to treat the patient in lines of the renal failure. Okay, next what else you have to do? Correction of hypoxia. How? By, by using nasal masks, face masks, or if needed, mechanical ventilation, intubation. Next, if the acidosis is severe, we give IV sodium bicarbonate. Next, treatment of cardiac arrhythmias. If the patient has developed cardiac arrhythmias, only if the patient has developed cardiac arrhythmias, you can go for the different drugs. Yes, only if the patient has developed cardiac arrhythmias, then you go for the different drugs, amiodarone, lignocaine, or cardio pacing, or cardioversion. And if the patient has developed septic shock, antibiotics, or if there is any drainage, if there is any abscess, drain the abscess. Okay, and low dose of corticosteroids can be given in the early stages of septic shock. Okay, so these are the general measures. Okay, next let us come to the drugs. Under the drugs, just now, as I told you, what are the drugs which we are mainly going to use here? We are mainly going to use the vasopressors. Okay, vasopressors and the inotropic drugs. Vasopressors and the inotropic drugs. So do you remember any inotropic drug? Inotropic drug. And do you remember any inotropic drug? If you do remember inotropic drugs, dopamine, dobutamine, vasopressors, any vasopressors, if you do remember, noradrenaline. Okay. So, but remember one thing, why have I written it down in the third point? Because these are to be used only after correcting the volume deficit. Okay, so first is that you have to correct the volume deficit. You have to correct the hypovolemia. After correcting the hypovolemia, then you should use this. Okay, so here mainly the sympathomimetic amines like adrenaline, noradrenaline. Okay, so how they are going to act? The sympathomimetic amines, they are going to act the sympathomimetic amines, they act by increasing the cardiac output. So how do they increase the cardiac output? By increasing the heart rate, increasing myocardial contractility, selective vasoconstriction. Okay, so by these two effects, mainly by increasing the the cardiac contractility, increasing the cardiac output, they allow the better perfusion of the ischemic zones. Okay, so wherever the ischemia has occurred and the the tissue perfusion is not adequate due to this shock, there is better perfusion of the ischemic zones, and there is redistribution of blood flow to the vital organs. Just now I told you, very important is that you should always ensure that your vital organs, what are the vital organs here? The heart, brain, kidney, skeletal muscles, sorry, not the skeletal muscles, I'm so sorry, the vital organs are mainly the heart, kidney, brain. Okay, so they are the different vital organs. So you should always try to redistribute the blood from, because skin, skeletal muscles, they don't come under the vital organs. Okay, so the main vital organs, most of, I think all of you must be knowing, it is the heart, brain, and kidney. So you should try to ensure that proper blood flow is received by these vital organs, the redistribution of blood flow to the vital organs. Okay, so now the main guidelines while using the sympathomimetic amines, that is, there should be an elevation of the mean arterial blood pressure. The mean arterial pressure levels, there should there should be elevation of the mean arterial blood pressure to above 65 mm of mercury, and you should always try to maintain a urinary output of more than 30 ml per hour. So this should be our guidelines when we are using the sympathomimetic amines. And the main inotropic drug which is used is your dobutamine. Although I'll give you some more names of some other drug sympathomimetic amines which can be used. But remember, dobutamine, that is the main drug, commonly used drug, inotropic drug, is primarily an inotropic drug which mainly increases the myocardial contractility. And in general, if you want to use a vasopressor, okay, to increase the BP, okay, so the main drug which is used is noradrenaline. Noradrenaline, this is the first vasopressor of choice. If needed, if an additional agent is required, even after giving adrenaline, you're not achieving your desired this thing, it's not causing effective vasoconstriction, vasopressor. So in addition, if it is required, you can add adrenaline. Okay, so or you can add dopamine. Okay, so let me just give you a list of the drugs, the commonly used sympathomimetic amines, which is mainly used in these cases. That is your dopamine, dobutamine, noradrenaline, adrenaline, isoproterenol, phenylephrine. Okay, so these are the common sympathomimetic amines which are used, commonly used sympathomimetic amines. But in general, I say you that, noradrenaline, remember, this is your vasopressor of choice. Okay, so this is your vasopressor of choice. If additional is required, you can give adrenaline, okay, so you can add dopamine. Okay, so usually, as an initial sympathomimetic agent, if the patient is presented to you with cardiogenic shock, so usually what we do is that we give noradrenaline or a combination of dopamine and dobutamine. Okay, so either you use noradrenaline or you use a combination of dopamine and dobutamine. That is usually preferred as the initial sympathomimetic agent in cardiogenic shock. The other agents which you can use is also written here. But remember, noradrenaline, okay, so this is the vasopressor. This is the first vasopressor of choice. Right? So dopamine, this already you must be knowing that there are 3 doses of dopamine which is used. One is, 3, less than 5, then 5 to 10 and more than 10. Okay, so one is less than 5 micrograms per kg per minute, then 5 to 10 and more than 10. These things already it is previously discussed under the dopamine. In your pharmacology portion, you must have been taught about dopamine. So dopamine less than 5, it has mainly got action on the D1 receptors. Okay, so then when it becomes from 5 to 10, it acts on D1 and beta 1 receptors. More than 10, it also starts acting on the alpha receptors. So when it acts, this is the preferred dose. Okay, so because when you give it in this dose, 5 to 10 micrograms per kg per minute, it is going to increase the myocardial contractility, heart rate by acting on the beta 1 receptors, as well as it is also going to cause the vasodilation in the renal blood vessels by acting on the D1 receptors. Okay. Similarly, dobutamine, the dose is 1 to 10 micrograms per kg per minute. Noradrenaline, the dose is, who all are interested in dose, they can listen to this. Noradrenaline, the dose is 2 to 8 micrograms. 2 to 8 micrograms per minute. Adrenaline, that is 1 to 8 micrograms per minute. So these are the common isoproterenol, okay, that is 1 to 4 micrograms per minute. Phenylephrine, 20 to 200 micrograms per minute. So mainly the drugs, these 4 you can remember, these 4 are important. Dopamine, 5 to 10 microgram per kg per minute. Noradrenaline, 2 to 8 microgram per minute. Okay, so these are the different drugs which is used. But again, as I tell you, I remember that noradrenaline, this is the first vasopressor of choice. Okay, so this is all about the different drugs. And this is the management. And vasopressin, you all know about vasopressin. So vasopressin, these are the main drugs which is used. Let me tell you a little bit about this vasopressin also. Vasopressin, this is, a hormone which is synthesized in the hypothalamus, is stored in the pituitary gland. When is vasopressin released? Whenever there is decreased blood volume, it's increased plasma osmolarity. So this directly constricts the vascular smooth muscles. It acts on the V1 receptors and causes constriction of the vascular smooth muscles. So by causing this constriction of the vascular smooth muscles, it can increase the blood pressure. Okay, so sometimes what is done, low dose vasopressin, usually 0.01 to 0.04 units per minute. This can be added to the sympathomimetic catecholamines. Just now we studied about all the sympathomimetic catecholamines. So along with this, you can add a low dose of this vasopressin to raise the blood pressure in patients with, if they're not responding. Okay, so first you do the general measures and you do the other things, still they're not responding, you give the sympathomimetic amine, still they're not responding, refractory patients, you can add a low dose of vasopressin that can help to raise the blood pressure. Okay, so this is all about the management of shock.